Hello, my name is David James, and I'm the chair of UAB's Safe Oversight Team. And with this video, I would like to build on our previous work about talking about why safe mobility is important and really get into the nuts and bolts of how do we set daily safe patient mobility goals. So at UAB Hospital, we use our John Hopkins Mobility Scale to document the highest level of mobility the patient does. This is what's observed the patient, what the patient observed doing with nursing or family. And that highest level becomes information we can use then to set the goal for the next shift. So when you think about the mobility score, it can help you think about what devices may be needed at the bedside to help with that, such as transfer devices or walkers or canes for patients that are ambulating. And then, so how do we go about setting the goal? What are the steps? So first of all, during report from the previous shift or handoff from another unit, you want to get a sense of what was the patient able to do? Were there any safe mobility concerns with the patient? And then in collaboration with the patient and family, determine what is the safe mobility goal for this shift. For example, is it up to the chair, which we have a mobility score of 4, or maybe it's to walk around the room and that'd be a mobility score of 6. You want to then, once you've set that goal, you want to clearly communicate that to the team. So that can be done by writing the goal on the communication board, or some units are using a laminated sheet. But again, how do we communicate that goal to the entire team? So you've talked with the previous shift, you've talked with the family and the patient, and you've identified the goal for the day, and you've communicated that goal by putting on the communication board. Now you want to assess the patient, determine who and what is needed to achieve that goal. And of course, you can revise the goal if needed based on the assessment, but what equipment and who on the team would be most appropriate to help the patient reach that goal. So when you think about setting goals for patients, we want to use our SMART goal format. So SMART goals are specific, measurable, achievable, relevant, and time bound. So when we think about safe mobility, we want to think about, well, who is going to help us do this and what exactly are they going to do, right? So by lunch, you need to do X, and then sit for the chair for how long? By 4 o'clock, we want you to do X. Is this a lap around the unit? How many laps? Again, be specific, make it measurable, and make sure it's time bound so the patient and family can achieve their goals and then be evaluated. So one thing we can do when we're setting goals is to connect the goals to the ADLs. So for example, if the patient's able to get up and toilet to the bathroom independently, or maybe with assistance from a PCT or mobility tech, then getting up to and walking to the bathroom, that's a 6. So that's how they can achieve that goal. If we think about providing their ADLs in the chair, so that would be a 4 or 5 if they're able to get to the chair, or if they're stand up, that could be a 5 if they're able to stand at the sink and do their ADLs. So connecting to ADLs is a great way to get those goals checked off and help the patient connect what they're doing to their safe mobility goals. And then assessment. So we talked about establishing the goal, communicating what the goal is, and now we want to assess and determine who and what is needed to safely achieve this goal. So to determine what the patient can do independently, what we want to do is coach the patient through the 8 steps in the John Hopkins Mobility Scale. At the point the patient is not able to do a step independently or safely, we stop and we create a plan to get the patient to the next level. So for example, you'd have the patient log roll, then push up and sit on the edge of the bed, sit unassisted on the edge of the bed for about 3 minutes, then sit to stand 3 times, how they then march in place, and then take some steps. So for example, if the patient was unable to sit and stand 3 times without getting wobbly, then you would simply stop, and they can safely get to the side of the bed fine. But to sit up and actually get to the chair, this is going to be our plan. Who and what is needed to do that safely? So when you think about safety, some things to consider is there a history of falls with this patient? What happened in that fall? Make sure the patient understands what their fall prevention plan is. Are there secondary diagnoses with the patient? And if so, what meds are the patient on with this? And is there any way we can reduce the polypharmacy? Are there any meds we're specifically concerned about related to fall risk? For gait, we want to make sure that we have we're assessing their gait. Do they need any gait assistance, such as a gait belt? Do they have proper shoes? Do they need any ambulatory aids, such as walkers or canes? Do they use those at home? Altered mental status, we may need a bed alarm or a chair alarm. We want to make sure the family is able to understand what our plan is for safety. And then tethers, what is attached to the patient? Is it really needed? And how are we going to address that tether when we safely mobilize? So we think about then we've identified our safety concerns. We have this plan in place. Who can help us achieve our plan? So this goes back to the buckets we talked about in our focusing on why video. So again, patients that are independent, up at lib, no oxygen, no IV pumps, the RN's okay, a family member or volunteer could welcome. Patients that need a little bit of assistance, maybe a little oxygen or tubes and hoses, or PCTs or mobility tech. Patients that we have safety concerns, first time getting up, invasive tubes or lines, the RN needs to be with the patient. And of course, therapy becomes our coaches, helping everyone get to the top of their practice. So mobility techs are a new role for UAB Hospital. They're assigned to select units, and we do have plans to expand to other units, so please stay tuned. But what is the mobility tech? What is their role? So mobility techs work under the direct supervision of a registered nurse to assist patients in reaching their safe mobility goals. Mobility techs may assist patients from the bed to the chair or help patients take laps around the unit. When we think about delegation and which patients would be appropriate, this table provides some guidelines and some guidance on who would be appropriate to delegate to. So when you think about fall risk, so family members, volunteers, we're thinking low and medium fall risk. Techs, whether it's a PCT or mobility tech, high fall risk. Nursing, of course, could be high fall risk. Think about oxygen requirements. Room air, of course, would be great for a volunteer or for a family member. 1 to 6 liters, PCT, mobility tech, high flow, more than 6 liters, RN there for safety concerns. IV pumps, infusions, 0 to 2, tubes or drains 0 to 2, we're thinking family member, volunteer. 2+, multiple stuff, we start thinking about having the mobility tech or PCT assisting. If you have multiple tubes and drains, multiple IV infusions, then the RN may need to be there to help manage and make sure all that is done safely. Hemodynamic instability. So if the patient is hemodynamically stable, then of course that's the tech and the volunteer. If they're unstable, the RN needs to be there. Able to follow commands. So of course that if they're able to follow commands and follow what you asked to do safely, then PCT, mobility tech, family member. If they're not able to follow commands, and of course the nurse may need to be there again for safety. So again, these are just guidelines and considerations to help you think about who would be appropriate to delegate mobility tasks to on your team. So what about when you're in trouble? What about when you have a SOS and you're able to help? So in our model, acute therapy become our coaches and consultants for safe mobility. So if you're not sure how to safely mobilize a patient, if you have a safe patient mobility question, if you need a refresher for safe mobility equipment, all you have to do is reach out to acute therapy. There are assigned therapists on each unit, as well as a lead therapist that's available to help. They're happy to serve as coaches and consultants to help you achieve your patient's safe mobility goal. So kind of wrapping up and tying this together in the process. So we really think about the RN being the quarterback for the team. They're going to set the clock. They're going to set goals to try to beat the clock. So making sure we have specific time measurable goals for patients, engaging the patient and family to help connect safe mobility to what matters to the patient, making sure the patient and family understand what's going to be required for safe mobility, and then using the team, appropriately delegating and engaging the team to help achieve those goals. Family members, PCTs, other nurses, or either the A&M if there are barriers. And of course, equipment needs. What equipment is going to be needed to safely achieve that goal? So once you've got your plan in play, then the other best practice is to have a mid-shift kind of check-in to see if we're reaching our goals or not. So have we achieved our goals? What are the tasks that have been completed? What are the barriers? How can the shift lead or assistant nurse manager assist in removing those barriers to help the patient reach their goals? So I hope this has been helpful. I appreciate your time. In our next video, we'll be looking at other best practices that we can use for safe mobility.